Thank you for the kind invitation, and it's always a pleasure to be here. This is my first time in the Kingdom of Saudi Arabia. So I'm going to present, the first part of my presentations is about myeloma, and the second part is on myeloma, but thinking about bispecifics. So talking about myeloma these days is including a bunch of different drugs that are available, and we're happy for that. Our patients do have some options. This is my disclosures. Today is the Mexican Independence Day. That's when I come from. Myeloma, as you know, is a plasma cell disorders where a group of cells, they look the same. Morphologically speaking, these cells look like a normal plasma cells that proliferate in the bone marrow. The median number of plasma cells is around 30% in patients that develop myeloma. But they do have the ability to produce abnormal proteins that we can measure through serum protein electrophoresis or free light chain. Sometimes they make both, the heavy chain and the light chain. But these lesions that they produce are lesions that can affect the bones. People can fracture, they can damage the kidneys, they can grow, and around 10% of patients might have extramedullary disease at the time of diagnosis. But they do have some genetic abnormalities that actually make them different between those group of cells. So this is a very key presentation from the Mayo Clinic group in Arizona, where a patient donated the bone marrow for research throughout the whole course of the disease. And you can see how in the beginning, there is a very small clone that is just pretty much not visible in the first circle when the patient was treated with, before the patient was treated with lenalidomide and dexamethasone, that is kind of the light green. And that's actually the clone that evolves at the end of the disease, with the patient actually present with plasma cell leukemia. So nowadays we think that there are between 4 to 6 different clones that are genetically different that expand and contract as they respond to treatment or become resistant, and that's what makes myeloma more difficult to treat. We always aim for cure because now we have drugs that could potentially give us good responses. But also, we do not sacrifice the best treatments available up front because there is no guarantee that the patients that we see at the time of diagnosis will be surviving, and the treatments that will be reserved for the second time of treatment or for the next relapse. And there is an attrition rate that occurs between one line to another. And depending on whether the patient is transplant or not transplant eligible, the non-transplant eligible might be patients that are more frail, more commonly seen succumbing of toxicities related to the treatments that we use. And that's why we offer always the best treatment up front, because there is a big attrition rate between lines of therapy, and we always like to offer the best treatment up front. We have made a lot of improvements, and you can see in this slide all the drugs that we have now available for multiple myeloma. And there are new avenues, there are new treatments, there are new mechanisms of action drugs that actually are available now that were not even thought about 10, 20 years ago. And that's what is making this disease now more treatable, and in a small population of patients that we hope will expand in the next few years. We're hoping that patients will live long enough that they might die of something completely different, and that's what we call functional cure. But when we talk about individualized treatment for patients with myeloma, that's something that has not only to do with the biological aspects of the myeloma cells, but also where some aspects that have to do with psychosocial variables, that has to do with geographic areas and access to different cancer centers, but also sometimes disponibility of the drugs, access to different medications, access to the cancer center. There are patients that might prefer to get oral treatments because they're unable to attend cancer centers for injectable drugs, or there might be some people that might have some preference based on convenience of what they consider is the quality of life. So the individualizing decision about treatment is always something that we do, not necessarily based on the biological aspects of the disease, but also based on some other factors that include geographical difficulty, challenges, access, and most of the times is what we have available in our cancer centers. Everything that we do for our patients has to be based on keeping them alive for as long as possible, but also to preserve the quality of life. And that includes some social disruptions, the ability for patients to work, access to transportation, the caregivers that might change depending what are the treatments that we offer to those people. So there are many considerations when we offer the treatment. So giving the best treatment up front thinking that the patient can stick to that treatment for the longest is what we normally do. And there is a high burden of all these treatments that we do and the effects of the myeloma itself that can potentially affect not only the patients, but also can affect the people that care for them. And those are caregivers that can develop stress, anxiety, or even depression, as you can see in this slide. And the quality of life of patients can also be affected by different factors that sometimes are not necessarily just related to the biological aspect of the myeloma. We do have treatments that are novel, and we have now drug combinations that could potentially give us deeper responses compared to what we used to assess 10, 15 years ago. And now we can even think of assessing the response based on the presence of what we call minimal residual disease, whether it's by flow or by some genomic abnormalities, because these drugs are so efficacious that people actually can have very good responses even beyond what we used to call the hematological complete response 10 years ago. So minimal residual disease is something that we're hoping that will help us to first assess deeper responses, but also in some people perhaps help us guide the treatment. The unmet myeloma is not only treating people with the right drugs, but also in some people is not to treat with drugs that might have some toxicity when they are not needed. So patients that are transplant or not transplant eligible that actually get minimal residual disease negativity do have a 67 to 68% reduction of the risk of death or progression when this status is achieved, which suggests that patients actually can have very deep responses that will translate into a better overall survival. But obviously, we're not going to offer different treatments that are toxic just to get to MRD negativity. Perhaps that might be something that is important, particularly in the group that we call high risk based on the cytogenetics, and perhaps might not be so important in people that might have a low-risk myeloma. What really matters is to keep it on the treatment that works for as long as possible, even if there is a small residual clone. However, the treatment can vary between patients. There are factors that have to do with physical performance, and some people might be more frail. The first separation that we do is whether a patient is transplant eligible or not transplant eligible, and the attrition rates may change depending on this. So as I mentioned to you, we always offer the best treatment up front because there is no guarantee that the second treatment might be available. But the patients that are non-transplant eligible tend to be older, tend to be more frail, and for those patients, giving the treatment that is more efficacious and less toxic remains the key important factor. And when transplant is considered, for the most part, we use the 65 age as a cutoff for different clinical trials, and that's an arbitrary number. In many centers, even patients over the age of 70 with good performance status can be considered for transplant. But nowadays, there is a challenge with these new drugs that we have, of even technological approaches like CAR-Ts and bispecifics. The question is whether the transplant will continue to be something that remains a key cornerstone treatment part, or whether we can actually substitute this for the novel treatments. So it is important to consider not only the biological aspects of the disease, but also the clinical characteristics of patients and the different comorbidities. This is just a slide when we can suggest that patients that are transplant eligible, we can offer different regimens of inductions, and the ones that I present here are the ones that actually are available in Canada for induction: the cyclophosphamide bortezomib and dexamethasone, the RBD combination of lenalidomide with bortezomib, and the addition of daratumumab with bortezomib, thalidomide, and dexamethasone. So there is a hope that by adding new drugs, potentially triplets or quadruplets, can increase the response that we see in our patients. And you can see in this slide one study from the European group where patients received induction with CyBorD, and then there was an intensification with BMP or the transplant, and then patients were randomized to receive consolidation or nothing. You can see in the Kaplan-Meier curve how the progression-free survival seems to be better for the people that receive transplant, but when you see the response rates between the group that received transplant or the intensification with BMP, you can see that the responses can be close to each other, but the deeper response is seen more with the transplant group. And it seems that particularly for the groups that might be high risk, doing transplant 1 or even 2, the tandem transplant might potentially be a good option to try to keep the disease not only controlled with good responses, but to keep it for longer. This is an interesting study called Determination, where patients receive RBD followed by transplant, And patients were then randomized to receive lenalidomide maintenance until progression. And what you can see right here is the same, that the patients that receive transplant do have a better progression-free survival. And the responses appear similar, but you can see that the MRD negativity is deeper for the people that receive the autologous stem cell transplant. There is some studies looking at what we call maintenance, and that can be given with lenalidomide, with studies based on bortezomib or ixazomib that have been less effective than lenalidomide have been suggested. But if you see the use of lenalidomide versus no lenalidomide maintenance, patients actually do have a better time to next therapy, progression-free survival, and even overall survival. So there is another study that is interesting where there was an idea of trying to prove whether the addition of daratumumab, this is something that can be in the phase of the induction, in the phase of consolidation, and even maintenance. And the idea was to see whether by using this daratumumab and making this a quadruplet, patients were to have a better responses. And you can see in the Kaplan-Meier curve, there is a 53% reduction in the risk of progression or death for those patients that receive daratumumab with BTD compared to those that only receive BTD. The responses appear similar when you look just at the raw numbers, but you can see that the MRD negativity is actually better for the group that received the daratumumab upfront. What is more interesting in this study is when you see patients that were exposed to daratumumab at any given time, and that's kind of the graph in the middle part at the bottom. Regardless of where the patient received daratumumab, the patients that receive daratumumab, whether it's an induction in the consolidation or the maintenance part, those are the patients that actually have the better outcomes in terms of progression-free survival, suggesting that perhaps the use of daratumumab, regardless of what phase is used, could potentially be the reason why the cells get more sensitive and they acquire better responses with higher levels of MRD negativity, as you can see in the right-hand side of the slide. There is another study that tried to look at the use of daratumumab, but in addition to RBD, and this was recently published as of yesterday in the Lancet of Hematology with updated form of this study, suggesting that the progression-free survival is better for those people that receive daratumumab associated to RBD, but what you don't see is any benefit yet on overall survival when the median follow-up is around 4 years. So this is to suggest that yes, you can get a little bit of benefit of PFS, but not necessarily overall survival we'll see, and perhaps that has to do with the fact that we have novel drugs that patients can be exposed in different lines. So getting a good treatment is always our first suggestion, getting the best treatment available for the patient at the time of diagnosis, but as we progress and we receive new drugs or we have novel drugs that might be accessible or novel technologies, patients actually can even get better. So this is the final analysis from the Griffin studies, and you essentially can see how the MRD negativity seems to be better for the group of patients that receive dara RBD. And this doesn't happen necessarily right away. It can take up to 8.5 months to receive the MRD negativity at the 10 to the minus 5 level, and around 33 months to get it at the 10 to the minus 6. But it seems that the patients that achieve the best response, the deeper responses, they correlate with better survival. But as I said, there might be groups of patients that could potentially use MRD to get therapy, and there might be others where not necessarily giving more treatment and adding more toxicity might be ideal, and that perhaps can be the standard risk of patients where perhaps a clone that is more an MGAS clone can even present a monoclonal protein that is left over, but not necessarily that will translate into a resistant mechanism of the myeloma cells. So a stem cell transplant is the first question, whether we do the stem cell transplant or not, whether we can do the different inductions that we have. But the patients that are not transplant eligible, those are patients that we could potentially offer kind of the same combinations, but we're going to assess some of those in the setting of being patients that are 65 or older. As I said, that was an arbitrary age defined by different clinical trials to consider transplant eligibility. And this is a study that includes patients that were younger than 65, but they were not intended to receive autologous stem cell transplant up front. And you can see that the patients that receive treatment with RBD compared to RD had a 26% reduction in the risk of progression of death, with responses that were higher, 90 versus 78.8% when compared with the lenalidomide and dexamethasone alone. This study is also interesting, where they were trying to compare the use of carfilzomib versus bortezomib as the proteasome inhibitors based on studies that were done in relapsed refractory myeloma that suggested that carfilzomib perhaps might be a more potent proteasome inhibitor compared to bortezomib. But as you can see right here, the progression-free survival doesn't appear to be different between patients treated with KRD and RVD. This study applies only to patients that were not high risk. Patients that were low risk or intermediate risk were only included on this study, so this doesn't address the possibility effect of carfilzomib in patients that are at high risk defined by the cytogenetic abnormalities. What seems to be revolutionizing the treatment of myeloma, particularly in the non-transplant eligible group, is the addition of daratumumab to lenalidomide and dexamethasone. Nowadays, we have daratumumab given subcutaneously, so patients actually can be treated within 5 minutes in an injection that is subcutaneous that decreases the amount of time the patients spend in the cancer center. And lenalidomide and dexamethasone, for the most part in non-transplant eligible patients, can be very well tolerated. So you can see right here that the progression-free survival is around 61.9 months compared to 34.4 months for those patients that receive dara-RD compared to the RD. And if you think of a patient that receives CyBorD followed by transplant and then lenalidomide maintenance, the median PFS that you see in a patient that are transplant eligible with that combination might be around the same, around 5 years, 4 to 5 years. This suggesting that MAIA, this study with DARA and Lendex, could potentially give us responses similar to what you might expect in patients that are transplant eligible with the combinations that we have. So this is a study that has revolutionized the use of treatment for non-transplant eligible patients with myeloma, provided that your country gets access to daratumumab. And there are so many places where daratumumab still don't become available. As you can see right here, DRD demonstrated a significant benefit of overall survival, 35% reduction in the risk of death when compared to lenalidomide and dexamethasone alone. So this is to suggest that this treatment that is less toxic could potentially give good responses. Not everyone gets MRD. Around 1/4 of patients get MRD and still they have a good response, perhaps suggesting that in some people, keeping a treatment more chronically without necessarily adding more toxicities can actually maintain the disease better control and increase survival. The MRD negativity, as you can see right here, seems to be better in a group of patients treated with DRD. And what really matters is not only getting to the deeper response, which is the MRD negativity, but sustaining this response for at least 12 months, and those are the patients that actually have the better outcomes. As you can see right here, the sustained MRD in the Kaplan-Meier curve in the middle, the one that offers the best PFS is the one that actually sustained MRD for more than 12 months. So this study is very important in this setting, and obviously the combinations that we have with RVD, DRD, and RD are still offered for people that are non-transplant eligible in Canada, and we also have combinations with VMP. Dara can be combined with that, and we have an exception where daratumumab can actually be given with CyBorD for non-transplant eligible. But to be quite honest, most of our patients will be receiving dara-RD if they are deemed not to be transplant eligible. But also there are variations of these treatments that could potentially have clinical significance, and that means that we decrease the toxicity of the medications that we use. And for instance, studies by the Italian group have actually looked at using less dexamethasone and stop it after 9 months, or adequate dosage based on age and based on the creatinine clearance, with the hope that patients will be able to receive the treatment for longer without necessarily sacrificing in terms of toxicity. And that is something that we have published even with bortezomib. Patients that are more tolerant, even with lower doses and sensitive from the myeloma perspective, can live longer and have better tolerability of the drugs, which translates into quality of life. And we have to remember that we individualize the treatment of patients with myeloma not only based on age and fitness and comorbidities, but also based on the biological aspects of the disease. So in someone that is a more aggressive myeloma, we try to give the best treatment that we have and the higher efficacy, but we have to also make sure that the patient might be able to tolerate that particular treatment. There are some studies that have been done with using oral treatment. Some patients might have the issue of not being able to come to the cancer center to receive injectables, and perhaps the addition of something that is oral might be adequate. There might be some changes that actually we have to make because of the pandemic, and we have to switch from Velcade to oral ixazomib, and many centers in Canada, that's what happened at the beginning of the pandemic. And this is a study that actually was negative. There was a benefit of ixazomib, lenalidomide, and dexamethasone compared to len and dex, but the most benefit was actually seen in the high-risk group, suggesting that perhaps the combination of dual treatment makes a difference, but this didn't actually fulfill the pre-specified goal that we have for the study, and is considered negative. And when you see the different combinations with daratumumab, you can see that the benefit of daratumumab remains regardless of whether the patient is younger or older, and in this case based on the 65. And you can see in Maya how this also translates into benefit, but the group of patients that are older, they might have a good benefit of the addition of daratumumab, but this decreases a little bit, which suggests that for our patients we have to always identify the best treatment but make it tolerable, and decrease toxicity is also important. And as you can see, the responses are better for patients regardless of age when the addition of daratumumab, and you can see that MRD negativity also remains. And this is a meta-analysis just comparing the different backbones added daratumumab, and for the most part daratumumab in addition to the VMP, VTD, and RD remains at the standard and the winner treatment. There is always a question whether we can actually use transplant later, and this is a slide when the data from the determination trial suggests that perhaps there is a group of patients where we can actually offer transplant for later, and that without sacrificing outcomes, and this might be something perhaps that we can consider more for the lowest standard risk patients with myeloma, where doing the transplant later perhaps might be still needed. But in the case of patients that are high risk, delaying the transplant could potentially be a little bit more dangerous, because the PFS, even when better with the new drugs, never gets to be similar to the standard risk group. So delaying the transplant in a small population of patients perhaps might be something to consider, especially with the addition of daratumumab to the treatments that we have presented. But obviously in some places the access of daratumumab might be an issue or more challenging, and in those patients perhaps when the transplant might be better. So that is the first part of my presentation, and I guess we'll move to the second one, or we'll stop for some questions on this one.